Now, what's interesting is that if you look at the GnRH antagonists, of which degarelix is probably the only one out there at the moment, it has a very distinct mechanism of action. As you can see on the left, and I've alluded to this before, LHRH agonists cause a surge of FSH and LH as well as testosterone, which again can be blocked by using anti-androgens. But the difference is that suppression of FSH is really not maintained for a long period of time. And then you get these microsurges of LH and testosterone on repeat injections, and it's also given people pause about, is that a reason why we're seeing androgen resistance? Is that the reason why some people reach a castrate level of testosterone of 50, whereas others may go down as low as 10? Is that maybe a reason why people are not covered as well as they should be? If you look at the antagonists, you immediately get a suppression of FSH, LH, and testosterone. And you recall I said within a very short period of time, but it's prolonged and you don't have those microsurges that may be responsible for people having the irregularities that you see sometimes with their PSAs. Now, another reason that degarelix is of interest is that there had been a pooled analysis, and again, nothing prospective, but everything has been retrospective, or population studies, for example, that looked at a variety of treated patients and cardiovascular history. And here, too, we have 6 phase 3, 3B trials, this time using or comparing degarelix with LHRH agonists. As you can see, close to about 2,500 patients, and they were randomized so that about 1,500 received degarelix, of which about 31% had some cardiovascular history. On the other arm, about close to 850 went on to an LHRH agonist. About close to 450 went on Zoladex or goserelin. The other equal number was roughly Lupron. And of that group, about 29% all told had some form of cardiovascular history. And the history is, as Dr. Gupta will talk about, will be myocardial infarction, some sort of coronary artery event, stroke, angina, or a bypass or even a revascularization. Dr. Albertson actually was involved with this and found, if you look on the y-axis, this is the cardiovascular event and death, leading to death. The light blue on your left represents the LHRH agonist, which was showing about 14.7% of those patients having a cardiovascular event, whereas on the right, or deep blue, in those patients who were on a GnRH antagonist, it was 6.5%, and that was a 56% relative risk reduction, which had a p-value of decimal .002. So clearly, significantly fewer cardiovascular events during the first year of treatment. Again, 4.5 versus 8.4 with an absolute risk reduction of 8.2. And the conclusion had been that you have an absolute risk reduction, which was 8.2, with a need to treat to avoid at least one cardiovascular event or death of being 12. And here, the cardiovascular events were exceptionally well annotated. They were arterial embolic, thrombotic events, hemorrhagic or ischemic strokes, and the like.